Right, good morning. On day 4 now of our tour of the knee. So we started off looking at Knee Anatomy 101, and then we looked at our medial compartment for day 2. Yesterday we looked at the lateral side of the knee and we looked at iliotibial band syndrome for day 3. Final day 4, we're going to be looking at patellofemoral pain syndrome, or pain around the kneecap. So quite common in adolescence, can be also experienced later on in life, and the two conditions vary slightly. Later on in life there's a tendency for the patellofemoral pain to be the result of arthritic changes between the kneecap and the bone beneath, and earlier on in life the pain tends to be more from stress on the soft tissues. So let's have a look at the condition itself, why it occurs and what it involves. So to understand it, we need to have a look at our knee once again, and we can see that the kneecap is on the front of the knee, and we've got our thigh muscles, our quadriceps muscles coming down. And what actually happens is that as the quadriceps come together to form the tendon, the patella tendon, the kneecap is actually within the tendon itself, and it gives a mechanical advantage. So it creates a leverage force so that the force from the quadriceps is magnified, if you like, so that when it feeds into the shin bone, the tibia, it becomes slightly more powerful. Now, the setup of the knee is one where we've got our hips wider than our feet when our feet are together. So we have an angle coming down from the hips to the knee. And as a result of that, the pull of the various quadriceps muscles have to be in balance. And one of the most common complaints, or the common features of this condition, is that we have slightly less muscle strength on the inner aspect of the knee than on the outer aspect of the knee, and that can occur through adolescent growth spurt, it can occur through pain at the knee, it can occur through changes in alignment. And what tends to happen is that because there's less strength on the inner aspect, the medial aspect of the quadriceps muscles, the kneecap tends to slide slightly laterally. And when it does that, it puts stress onto the soft tissues, and those soft tissues can become irritated and slightly tightened. And one of the culprits on the outside of the knee we mentioned yesterday was our iliotibial band coming down the side of the knee from the hip, and as it comes down onto the side of the knee, there's a thickened area which attaches to the side of the patella, so that iliopatellar band can be a little bit tight, and that tightness on the outside combined with slight muscular weakness on the inside just means that the patella it moves slightly laterally. And when you look at the patella in cross section, you can see that it's triangular and it fits onto a groove into the front of the thigh bone. And normally the fit of the two is quite precise. So we've got our V-shaped kneecap sitting on within the V-shaped groove of the femur, and sometimes what happens is that the patella moves slightly to the side, and you almost get a sort of a scraping effect of one structure on top of the other. So what do we do about this condition and how do we recognize it? So it's commonly more painful coming downstairs, and it's commonly painful when you sit for a prolonged period, and this used to be called the cinema sign, where somebody was sitting for a long period, they stood up, the first couple of steps it was quite painful, as they got going things started to improve, and that's a sign of this patellofemoral pain syndrome. So we've got a number of ways that we can address this, and this moves back to what we mentioned in our first video, Anatomy 101, where we said, well, the knee joint is in the middle of a chain of movement. Above it we've got the hip, and below it we have the foot. So we can change things in the foot, and we can change things in the muscle to alter, in the hip muscles rather, to alter the stress around the kneecap and help to resolve this problem. And of course we can address the knee directly. So how do we address the knee directly? Well, one of the things that we'll use within physiotherapy is taping. And what that taping will do is basically alter the load on the patella. And when we do that, changing the load alters the response of the tissues and can modify the pain. Now, many years ago, we used to believe that there were various precise measurements that we could take on the patella, and we could move it slightly to one side or slightly to the other side, or we could revolve it a little. Nowadays, most of the research has shown us that if we simply put a piece of taping on, draw the kneecap into a medial position, because the taping is actually affecting the skin, it won't have a direct effect on the kneecap, but what it will do is it will alter the stress on the tissues, and by altering the stress on the tissues we allow those tissues to recover. And of course it also makes you more aware of the kneecap when you're moving, and so that in turn can alter your lower limb alignment. So taping on the knee can be quite useful. The second thing we can do is to address the lower limb alignment from the foot. So if the foot is flattening excessively, when your foot flattens, your knee naturally twists, because the flattening of the foot has to be compensated, and it compensates through lower limb alignment. So if my foot flattens, my knee swings inwards. So the use of a more supporting shoe, or the use of an orthotic in the shoe, can reduce the rotation of the ankle and the foot, the twisting of the tibia and the twisting of the knee. So when that happens, that can be used to reduce the pain from patellofemoral pain syndrome. And the final thing we can do is to work on the hip muscles that we mentioned yesterday. So if you remember, we said that our band down the side of the leg, our iliotibial band, had two muscles from the hip feeding into it. So we can use the exercises that we mentioned yesterday, standing on one leg, hands on the hips, and all we do is we hitch the hip upwards. So that's working these muscles. And as a second option, we stand on one leg and we bend and straighten the knee. And as we do so, we make sure the hip doesn't dip down, because that hip dipping is a sign that we use when we're examining lower limbs alignment with a view to resolving patellofemoral pain. So we call that hip dip a Trendelenburg sign. So somebody stands on one hip, do they maintain the level of their pelvis, or does the pelvis dip? And if the pelvis dips down, we say that's a positive Trendelenburg sign. And when it goes further and it dips down and they compensate by leaning to the side, that's a compensated Trendelenburg sign. So the physiotherapist will assess that, and that can determine whether your hip muscles are powerful enough to control the alignment of your pelvis over your leg. And if they're not, that can put stress onto the kneecap. So we can address things in the foot, We can address things around the knee itself, and we can address things in the hip. And when we do all three of those combined, the condition can be managed relatively well. Okay, so we've got more information on this on our website, www.norrishealth.co.uk, and we've got two resources on that. Firstly, if you scan along to our blog section, there is a blog on patellofemoral pain syndrome. It's got exercises on it, and it's got a link through to our YouTube channel, which is youtube.com/Norris Health, and you've got a series of different exercises that you can perform. So we've got some of the foot exercises, some of the knee exercises, and some of the hip exercises, which are used to address patellofemoral pain syndrome. Okay, so that's our final knee video. So we've had 4 videos, then we've had knee anatomy, medial pain, lateral pain, and now patellofemoral pain. Hopefully that's been helpful. Have a look at our website, have a look at our blogs, and then if you need any assistance, give us a phone. We're in Congleton, 01260 290 564. Many thanks and have a good Easter.